The Next Breast Thing podcast is primarily funded by the American Society of Breast Surgeons. The support of sponsorships helps us offset some production costs. ASBRS does not endorse or co-promote any company, product, or service mentioned.
This episode of The Next Breast Thing is made possible in part through the generous support of Myriad Oncology. Learn more at www.myriad.com. And from Solventum Prevena Therapy. Learn more at www.solventum.com.
Myriad Oncology provides a portfolio of advanced genetic and tumor genomic testing solutions, including risk assessment, screening, tools to aid treatment guidance, and survivorship planning. The Myriad Oncology offering is designed to meet the unique needs of oncology specialists and their patients across each step in the patient care continuum.
To learn more, visit myriad.com/oncology.
Solventum Prevena Therapy has demonstrated a significant reduction in surgical site complications, infections, and readmissions. Take a proactive risk management approach. With Prevena Therapy, learn more at Prevena.com. That's Prevena.com.
Hey listeners, want us to let you know when new episodes are available? Simply hit the subscribe or follow button on the Next Breast Thing podcast, wherever you listen to podcasts. Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
On this episode of The Next Breast Thing,
I have a Bovie update. Now, for new listeners, Bovie, as you recall, is the name of my former calf.
so we did a low-budget mud race, did not get electrocuted.
Our topic today is the sound trial in practice. It is.
How do you guys get buy-in with something that might change other people's management?
And I say this is where we are right now. If you're going to do the omission of the
And
sentinel,
they'll say, oh, this could be a site for future seeding. It's like, have you people not looked at this data for the past?
we do have this gray zone right now. I think a lot of people can agree, greater than 3 centimeters, they typically.
As a newer surgeon, your mindset is very risk averse. You're worried about getting sued,
I love the idea of being that innovator, but I also don't feel like I personally have the backing.
These are 3 of the most important takeaway messages that we have had about developed protocols.
This is Carla,
Ellie,
Michael,
Susie,
and Susan. Welcome to The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the entire breast community.
We're a group of devoted surgeons from different parts of the country,
inviting you to journey with us into the science of breast
through the heart and soul of our breast community.
From advances in procedures and patient care to personal transformation, we're here to support you.
So, if you're part of the breast community and can't seem to find the answers, this is the next breast thing.
Our topic today is the sound trial in practice. It is so involved and really involves not just surgery, but what we do with medical oncology, what we do with radiation oncology. It's so complicated in this. But before we get started, let's do some interesting things and talk about some personal and professional updates. Ellie, let's start with you tonight.
Sure. So I actually just got back from your neck of the woods, Susan. I was just in New York City.
And you did call?
I'm sorry, Connecticut, New York, you know how it goes. But I was there for a week. I was in my old stomping grounds, which I lived in Brooklyn when I was there, and went to all my favorite restaurants, walked around. It was great. And I walked like 10 miles a day. So that's my favorite thing about New York is all the walking.
Okay.
And
So
many other things.
what changes did you notice in New York City from when you were here? Because it's definitely changed. I'm in the city a few times a week. It's definitely changed.
The cell phone being able to be used on the subway, game changing. Like, you know, I always had the subway card, and now you can do the Apple Pay, essentially, on my phone. I didn't buy a subway card. which is the first time I've ever done that.
I didn't even know that. I'm not a big Subway person. That might say a little bit about me.
Did you miss all the crime and all? She never looked up from her phone.
I was wondering about...
That's where I thought this was going, and it did not. It was just the cell phone. Wow.
Yeah, it's not as clean as it used to be, but yeah, let's talk about that you didn't need a Metro card or something.
Yeah, it was great. But no, it was the same. Otherwise, it was exactly the same. What about you, Michael? How's everything with you?
Well, I have a Bovie update. Now, for new listeners, Bovie, as you recall, is the name of my former calf.
Former what?
Oh, no.
What?
Former. We loaded Bovie up into the cow hauler thing, and off she went. You know, I don't know if you know this or not, but I'm a rancher, and now I have a cow-calf operation. So I sold Bovie. I have no idea what's happened to her. I never wanted to name her like you guys did because I knew this day would have been
Really upset.
There's a song about she's gone. She's gone. Now we've got to wait another, I don't know, what would you say the gestation is? Like 9 months?
10 months?
10 months for Bovie 2.
This is like operative equipment, right? When you buy something, the new version comes out.
Now, unlike you, I didn't have to wring its neck and teach the kids that we're going to eat it for dinner. I just watch mine go away and wave. It's a little cleaner that way.
I don't know about you guys, but I'm really bummed about this.
Well, you know.
End of an era.
Enjoy your hamburger. Susie, tell us about how you've sold animals off for food.
Okay, I have not sold animals off for food, but you all do know I like adventure and I like kind of different things. So we did a low budget mud race. Did not get electrocuted. There's some of these mud races where, you run a long distance and do all these obstacles, and one of them's an electrocution event. We did not do that.
Good grief.
We are very familiar with mud races, but I don't know anything about electrocution.
I want to see her internet search history. I have no idea how you even find these things.
My personal goal was to make it to 3 rings on the monkey bar action on that, and I barely touched the 3rd one before I dropped into this huge mud puddle that is not my strength. And there was this other obstacle where I'm like waist deep in mud, and then you have to crawl up this hill, and someone is like trying to hold your hand, someone else is pushing your feet, and what's supposed to happen is at the top of this slippery mud hill, you're supposed to slow down and help the person behind you. Well, I had so much momentum that I flew off this hill and went face first into the biggest mud puddle ever. So like on obstacle 3, I was done. I was completely covered and I had to run the rest of the race, and you're just like slogging with mud the whole time. But it was really actually quite fun.
Did you pay to do this?
Yeah, I don't know about anyone else, but really, that sounds awesome. Wow, can't wait to see.
Pull up Ellie's business acumen on this and see how that was a bad investment.
It was fun. My daughter, her boyfriend, his mom, and I, we all did it together. It was a fun activity.
Team building.
Yeah, I really do appreciate how different people have different definitions of fun. I think it's great. Yeah. I've had a few weekends of family weekend at colleges with my kids, and now that's fun. The pregame, but then there's a pregame to the pregame, and then the frat parties, and then the tailgate, then the game, but you may or may not make it to the game. You frequently do not. So that would be my definition of fun compared to being electrocuted in mud.
Aren't you a little old for these frat parties? I mean,
Listen,
was there Grandma Day or something? What was that all about?
I have to say, I don't think I could make it through college again, but wow, it's fun.
Did you see other parents trying to relive it as if they were?
Someone was telling me today that they went to family weekend and they were at the frat parties, and they actually had to stay 2 days longer because their husband couldn't get out of bed after it.
Grief.
He hit it hard and could not rally for 2 days.
Yeah, this is real. Yeah. Like on Parents Weekend here, as a general and trauma surgeon, there's often a parent that is in because they hit it too hard.
Oh, yeah.
None of my schools were like this, no.
Oh, sure.
They weren't.
You're just saying that because you're depressed because Miami has a better record than yours.
Many schools do.
I mean, after the first week. Miami had a better record, so it happens. But let's move on to our topic. For decades, sentinel node biopsy has been basically the mainstay of treatment. And if we back up even further, axillary node dissection, it wasn't that long ago. The 90s, axillary node dissection was standard, and then sentinel node biopsies came into play, and frozen sections. Everyone was doing frozen sections and still axillary node dissections. But we really are advancing this field. And we really do believe in de-escalation and that less is more. So today we're exploring the implications of the SOUND trial and ENSEMA and the various trials exploring omitting sentinel node biopsies. What's the takeaway from these trials, and how are we implementing them into our individual practices, and what is our hospital doing? But also, how do we talk to the patient about this? How do we involve medical oncology and radiation oncology in this? So, Ellie, let's start with you. What's your take on it? And have you discussed this with your medical oncology colleagues and radiation oncology colleagues?
Yeah, so I have heard the trial, read the trial, talked about it at our tumor board. Once it came out, our breast surgeons got together and we did a little review of the SOUND trial with our colleagues so that everybody is up to date and kind of knows what just came out. And then we opened it up to questions and concerns. And I think that exercise was super helpful because the radiation oncologist piped up and said, hey, well, I use a node to decide if I'm going to give someone partial breast versus whole breast versus omitting radiation altogether. You just heard the other sides of the aisle. And that conversation was super helpful. And it helped us kind of come to a group consensus that was, okay, we're willing to go with these criteria of the guidelines of women less than 50 with really luminal A, small cancers, grade 1 or 2, blah, 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 all that criteria. And then in practice, what I've done at least is if ever I'm talking to a patient about it, before surgery, I'll have them meet also with the medical oncologist and radiation oncologist just to be sure that everybody's on the same page with this process. And again, I don't know if that's right or wrong. This is kind of the first big practice-changing trial that's happened in my early career. So that's how I've rolled it out. But what about you guys? How do you guys get buy-in with something that might change other people's management?
So right now, what did you say the age was for you?
We go off of like the ASCO guideline, so over 50.
And that's really what you're implementing, over 50 luminal A.
Luminal A.
Are you doing a lot of whole breast radiation or partial breast radiation?
We do a good amount of partial breast as well as whole breast. We just started implementing this maybe 6 months ago, so we don't have a full year's data on that. But we still are continuing to do partial breast in certain patients.
So it's interesting because when you look at the SOUND trial and ENSEMA trial, they're basically whole breast radiation trials. So to apply this and say, hey, it's okay to omit the sentinel node and do partial breast radiation, some people consider that a leap. Susie, what do you think of that?
We definitely have that discussion as well because it's a de-escalation on two different arms. At our institution, we have an open discussion about it and an open discussion with the patient. And literally,
what does an open discussion mean?
Oh, for us, it means that, I say in this trial, there was no difference between the two arms in the SOUND trial, whether they had work done in the axilla or not in distant disease-free survival. But they did get whole breast radiation. And so it is a conversation about
so Susie, I'm going to push you on this because I know we talk a lot about shared decision-making and all that. Patients are coming to you for your recommendation. You have a 55-year-old woman sitting in front of you, 1.9 centimeter cancer, clinically node negative, luminal A cancer. What is your recommendation for sentinel node?
I say, according to this trial, for a 55-year-old, I would recommend you could omit it. But then in a 55-year-old, I recommend whole breast radiation. I think that there is a discussion of partial breast, but that does make me more nervous in a 55-year-old because there's a lot more years ahead of them versus someone who's 70.
Okay, what about a 65-year-old?
Michael, what do you do with the
No, Susie, you're on the hot spot.
I was
to Michael.
I think it's the same discussion, though, Susan. I do. I think you have to talk about, like,
you have to have a recommendation.
You do.
And then you back up the recommendation and you say at the end of the day, it's your decision. But here's my recommendation. Here's what we do. Here's our protocol at my hospital.
Mm-hmm. And I think there is a difference with 1.9 centimeters, where what the average tumor size was in the sound trial versus in choosing wisely some of those guidelines, it was less than 3 centimeters, but the age was very different on there. And I believe that that is still a discussion with the patient of you can choose to have a sentinel lymph node biopsy and have partial breast radiation.
So Enzema included T2s.
There was lobular as well. And I think that's different too. It's a smaller percentage. The T2s were a smaller percentage. There were even 40 to 49-year-olds included in this. That's also a smaller percentage of that. So I like taking the majority of the patients. And I say this is where we are right now. If you're going to do the omission of the sentinel lymph node, these trials were done with whole breast radiation. We can still have a discussion about partial breast radiation, and you have to know the risks. And some people feel good about that, that if they had a recurrence and they only had partial breast, what are their options?
Do you have a protocol at your hospital for this is 65 and up, luminal A, we're good with applying this and still doing partial breast? Is there a protocol at your hospital?
We discuss every individual case at our tumor board.
So you discuss it before or after you see the patient?
It's usually after I see the patient, but it might be before medical oncology or radiation oncology has seen the patient. And if any person on the team really feels strongly about it or that there would be a difference in care, we can bring that back to the patient. But I would say the majority of the time, we are comfortable with applying the sound trial of omitting the sentinel lymph node biopsy.
In what age without changing other parameters? Because there's definite evidence, and we know that whole breast radiation can have worse aesthetic outcomes and longer term impacts compared to partial breast radiation, especially in younger women. So where's the trade-off? I think that's where I'm trying to get to. Michael, where are you comfortable without changing other treatments?
And this has really messed the whole algorithm up for all of us because they are, like Susie said, sort of intersecting de-escalation trials. So you just sort of have to present each option and what is it that you're trying to de-escalate. I've thought lymph nodes for years has been just a surrogate for disease aggressiveness. And we're still stuck with these other trials that node positivity matters, where I think the biology matters much more. I would love for there to be a day where we don't even have to check the nodes because the biology states the case. I've been fortunate because our radiation oncologists are willing to do partial breast radiation in the right setting. Now, again, what is the right setting? It's not been real well defined. And it does come down to what does this individual patient look like? Enzema went up to 5 centimeters. Most of the cancers weren't 5 centimeters, but enzema went up to 5 centimeters. I don't know that there's going to be a lot of people on my tumor board that are going to be real happy with avoiding some sort of nodal evaluation currently. But, if you've got a luminal A breast cancer, even if it's 4 centimeters, it's still not real likely that you're going to have nodal positivity, especially if that axillary node looks normal on ultrasound. And even if it is, we know from Z11, we're leaving positive nodes behind. I think it much more relies on the biology than it does whether or not a cell escaped to the axilla.
Can you talk about a trial in the history of trials that has shown a difference in overall survival with doing an axillary node dissection?
No, because there aren't any. And that's really interesting because but boy, you get in a tumor board and they'll say, oh, this could be a site for future seeding. It's like, have you people not looked at this data for the past half century? Nodes just don't matter for survival. Now, you could parse out SEMA and sound in the types of cancers that you're looking at. I don't know that 5 and 6 year follow-up is enough for luminal A's. I think we're going to need to push that out to probably 10 years.
But, or even 20. But we have to change now. I mean, are we going to wait for 20 years because it's luminal A before we make a change?
No, we're not. And that's where it goes to biology. I think there's a few trials now, like I-SPY, that is looking at tumor biology. I think that's going to be a real important shift. I would love to see all trials abandon, to some degree, this nodal criteria, and let's hang around more with tumor biology.
I agree. I think with a lot of other cancers, we can see once there's that potential for spread, that it is not a surgical disease. And I feel that this is catching up in that sense, that it is not removing 8 lymph nodes that's the game changer for the patient. And now we're saying, is it really even 1 or 2? But I do agree with you, Susan, that we do have this gray zone right now. I think a lot of people can agree greater than 3 centimeters, they typically get some form of whole breast radiation. How that's parsed out, it can be very different. With the less than 2 centimeters in a younger woman, I think there is some degree where people are more uncomfortable because we don't have that 10, 20-year data yet.
So I usually think that there are a few types of people. The people who want to go out and make the change and they're designing the trials or they're enrolling people in the trials. That's one group. One group is, I don't care what this trial says, I need more information. They're going to finish their career doing things the same way they started their career because they're waiting for the 20-year. I don't know. I know there's good data with sound and SEMA, but I need 20-year follow-up. Ellie may be the only one still working 20 years from now. I don't know about the rest of us, but
she has so many other investments, man.
Ellie, you're going strong 20 years from now. And then the third group is, tell me how this applies to me. Give me the argument, and I want to make the change. Just tell me how it applies to my patients and what I can do. Michael, which group do you want to be in?
Well, I've always kind of been a push the envelope person, and you can sometimes get burned doing that. I think the main thing with that is you're going to have to inform the patient that this is new data. This is what we know about it so far. And we may look back and say that in these particular instances, it wasn't a great idea or whatever else, but as best you can, tell them about the competing evidence of de-escalation. And I've always kind of joked and said that shared decision-making probably doesn't really exist because, like you said, patient doesn't have this fund of knowledge, but you can give them at least some options as, hey, we're going to de-escalate what's more important to you. But I have been kind of a push the envelope person. Fortunately with Z11, fortunately so far with cryoablation, that's worked in my favor. There may be times where it doesn't work in my favor. But again, we've seen so long data that removing nodes just doesn't matter. I feel very comfortable with nodal emission.
So Ellie, you are young in your career. Which group do you want to be in? Because that answer may change as you go on in your career. I don't know, Michael, if a year or two out, you were a push the envelope sort of guy. I don't know. So Ellie, what do you aspire to be in which group?
Initially, of course, when I'm just coming out, I want to do the board answer, the safest thing, the things that I was taught were tried and true. But luckily, I have been surrounded in an environment where my colleagues are envelope pushers. They are saying, hey, we're probably overtreating this. We're probably doing too much. And that has really challenged my mindset, which as a newer surgeon, your mindset is very risk averse. You're worried about getting sued. And especially when a new guideline comes out that you just don't have the reps of explaining these complicated things to patients. So it takes some time. But of course, my goal is to be on the forefront of stuff and not be overtreating in a certain type of disease. Do I want to be de-escalating in triple negative HER2 positive? Probably not. From what we're understanding, those probably aren't the right people. Even though there were some in these trials, they were very small amounts. That's probably not the right group. In my early understanding, I put people in two groups. I put you in the hormone receptor positive, kind of luminal A group, and then everything else. And the first group I talk about is who I try and de-escalate and who I try and get myself comfortable with giving more options. And the patients deserve that. They deserve to maybe not have a scar in their armpit and lymphedema if we can possibly offer that to them. I want to be in that innovative group, even though the mindset of an early surgeon, it's hard to do that sometimes.
And sometimes being in that group is just enrolling patients in clinical trials. Mm-hmm. And frequently we just have to trust the data. I mean, the data's here. Mm-hmm. Susie, your thoughts?
Well, you all know I love to push, but that's usually with like athletics and vacation and things like that. But as a breast-focused general surgeon, I am definitely in the category of how does this apply to me? I love the idea of being that innovator, but I also don't feel like I personally have the backing as soon as something is new. But I love it when it's published to then bring forward that to our tumor board and work together with our colleagues. I feel like there's always four pillars. There's a patient, there's me as the breast-focused general surgeon, medical oncology, as well as radiation oncology. We have to come together and figure out how this works best for that patient.
So I hear what you're saying. I would encourage you to come up with some sort of protocol. So as opposed to a patient coming to see you and you saying, well, maybe we'll do this, maybe we'll do that, and then going back to tumor board and discussing every patient. And as your volume increases in a hospital, you just can't possibly discuss every patient at tumor board. The numbers are just too high. I'm saying as volume increases, I don't know how many patients you have, but if you're seeing 500, 600 breast cancers, 700 breast cancers a year, you just can't discuss every patient in detail at tumor board unless your tumor board is 3 hours long every week. I don't know. And then if you're discussing it at tumor board, then you have to come back to the patient and say, yes, this is what we're doing. So it's a few visits, it's time, as opposed to coming up with a protocol of, okay, every luminal A, 65 and over, we're going to omit sentinel nodes and start somewhere. Is it 70 and over that you're omitting sentinel nodes? Where does that comfort lie?
We do have that, but what it is when I have that visit with the patient, I say, this is where I think you should be, and we have an agreement on that. And if someone else disagrees, they are allowed to speak up. We have a really tight community. So I feel good with how we do it, and I love that we actually do discuss every single patient.
I think it's a luxury to be able to discuss it.
It totally is. We're in a really unique situation that we can do that.
But as volume increases, it just becomes very difficult to do in-depth discussions on every single patient. There's a tipping point at volume, and that varies in every situation.
How many of you guys push the envelope where you're doing your own ultrasound and trusting that you're going to do the axillary ultrasound yourself and you're the one that makes the call? Because we're in a system that's a little bit different from you guys maybe, in that we're in an oncology group that serves a 3-state area. So the level of breast imaging is all over the place. So we may have somebody that comes in that has a mammogram and it may be fine, but the axilla has not been evaluated. Any of you guys feel comfortable doing an axillary ultrasound and making that call yourself?
I don't feel comfortable with that. I would want a board-certified radiologist doing that. I have not had enough experience doing dedicated ultrasounds on the axilla that I feel comfortable being like, yes, Your Honor, I made that call.
So I think comfort is an interesting word and has so many different implications. So Susie may be very comfortable in her own skill and say, yeah, it's clinically node negative, but documenting that and having the comfort to then stand up in a jury if something happened, that's a different level of comfort, or maybe a different level of confidence in how we're doing that. So I think comfort is a word that has so many meanings in this situation.
And we'll absolutely do. I mean, the ultrasound certification certainly helps. You've had people that have reviewed your images and you've taken a test and you've submitted a certain number. So there is that bar set with certification that does provide a little bit of support that you know what you're doing. This isn't your first ultrasound. So I feel very comfortable looking at the axilla myself, recording images, documenting that, and making the call. And it's going to be different all over the place.
Ellie?
No, I do not feel comfortable doing that at all. I'm not certified in ultrasound. And although I did fellowship and of course did my ultrasound numbers, I definitely would not hold that up in a court of law that my axillary ultrasound is even close. I can of course find a lymph node, but can I tell you if it's normal? No. I still get confused when they're like, oh, the cortex is this thick or this. I'm like, where do you see that? There's definitely a gap in my training versus the radiologist training. But if you're in a situation like that where there's not that many breast trained radiologists, the surgeons do need to step up and take the ownership of the ultrasound. That probably makes the access so much easier. So just because that's not my situation doesn't mean it's wrong. I think that's great that you guys get to do that.
So going back to protocol, how many of your breast imaging centers have a protocol to always look at the axilla if there's a suspicious mass?
All of them, 100%.
Michael?
Ours does, but again, we get images from other places. And if that's the only thing lacking, then I feel comfortable doing that. If they come in with just an inadequate imaging altogether, we just send them down the hall. But you're right, it has to be done. That is part of the workup.
Right. So how many would take a patient to the OR without an axillary ultrasound these days?
You shouldn't.
I would not.
No.
So I think that's an incredibly important point in that protocols for our radiology colleagues have changed in that they are doing, especially in the more experienced centers and the higher volume centers, they are doing axillary ultrasounds. Now we know ultrasound is operator dependent, but still they're overall being done. I would venture to say that anyone who's doing a fair number of breast cases is not going to the OR without an axillary ultrasound. At least I hope so. So on that topic of axillary ultrasound, how many clip a biopsied node?
There's no reason not to leave a clip in everything you biopsy. And I know they don't do that in some places, and they make a big point of it.
Correct.
However, it adds nothing negative, in my opinion, to that procedure, and it opens up more opportunities if you need it.
And do you do a mammo following clip placement?
Yeah, but it's also hard to see it sometimes depending on how high in the axilla it is. We do a post-biopsy mammogram for sure on the breast. If it's high in the axilla, I have a picture on ultrasound of the clip indwelling within the lymph node. So at least I have some documentation that the clip did in fact deploy.
If you are doing the ultrasound biopsy and therefore you are placing the clip, who's doing the mammogram and reading it?
We've got imaging departments, so we send it down for a post and they read that. I don't read the mammogram. I'm not MQSA certified, but I can read an ultrasound, whether I'm certified or not. We're allowed to do that. That doesn't fall within MQSA.
And Susie and Ellie, do your radiologists have any issues of verifying clip placement in a lesion that they did not biopsy? This is an issue for some radiologists.
At our institution, we ask if you are going to do an ultrasound and biopsy it yourself, you need to have done the certification and had those numbers documented. Most of us allow radiology just to do the whole thing. Would they read it if it happened outside? Yes.
And some people are just being difficult, Susan. I mean, and I know those points exist.
I don't doubt it, but this is an issue for breast surgeons across the country in different places doing image-guided biopsies that the radiologists, right, wrong, indifferent, are saying, hey, we're not reading and verifying clip placement for a biopsy that we did not do. And if you just step back, I see their point.
But I think
I do a little bit, like even more so, not just the business aspect of it, but what are they saying? There's a clip in a node?
Correct.
I understand what they're saying.
It's not their loop to close. Yeah.
Right. And I'm saying I see it from their viewpoint. I know, Michael, you say that maybe they're being difficult, but I do see it from their viewpoint. We're asking them to verify that the clip is in the biopsied node when they didn't do the biopsy. They don't know what node it's in.
Do you read your specimen radiograph?
I do.
Who interprets that?
I think
Both
that's
of us.
two different questions.
Well, I know, but I'm just saying, I'll interpret that. Now, they may come back and read it a day later, which serves no purpose, but I can interpret that there is a clip that I see.
Correct. I interpret it, and it is sent through PACS to our radiologist to do the official read to close the loop because they've placed the seed.
Mm-hmm.
So perhaps if I placed the seed, I would both read and do the formal interpretation, but in my system, the radiologist places the seed. Although I look at every specimen image and interpret it in the operating room, I do not do the formal read. It's sent to the radiologist. They call right back with it.
So you wait for their read before you allow the patient to wake up?
Oh, it's within 3 minutes.
Okay.
So we remove the specimen, we ink it, we take an x-ray, and it gets sent automatically. And by the time I'm walking back, they're calling with it. So no, there's zero delays there.
What does the sound trial say about specimen? I'm just kidding. Sort of got off.
We got off
the rails a little bit.
A little bit. Isn't that shocking for us? But last topic, because this does pertain to the sound trial and what we were talking about, partial breast versus whole breast. Who marks the cavity after breast conservation or a partial mastectomy or a lumpectomy, whatever you call it?
I do.
You mark the cavity, and if so, with what?
I do with surgical clips.
Yeah. I mark it with titanium clips, 3 different planes.
Mm-hmm.
I do too. Now, if you start throwing oncoplastics in there and the clips start moving around, those are great questions to have. I do that. And if somebody comes in and resects part of the lumpectomy margin, what happens to those clips? Or if you're really doing a big tissue rearrangement, I mean, they may not even be in the same quadrant. So, but I do it every time. And then what the result is sometimes can be very different.
That is the difficulty with oncoplastics, especially when you're doing larger oncoplastics and clips, in that they can move around, and then partial breast radiation becomes very difficult in that situation. So there are other products out there that really allow you to close that cavity down or mark that cavity and then do the tissue transfer or oncoplastics around that. So that's what we use in our system because we all do tissue transfers or larger oncoplastic procedures.
I do miss the little gold clips though. That was fun during that trial of like having the real gold.
Ooh, that's cool. Do you like that suture stuff?
I do very much, and more importantly, or equally as important, our rad-oncs love it.
Okay.
So we do the overwhelming majority of radiation that we do is partial breast radiation. They have a very high level of confidence in that they know where the cavity is or where the cancer was.
What about the mammograms after? Do you like that, how it looks there?
It's fine. We actually had a symposium and asking the radiologist their thought. And they were like, it's so easy to know exactly where the cavity was. So they also like it. So everyone seems to be happy. But before we close out this episode, one takeaway message. Susie?
The takeaway message from today is to evaluate where are you on this stages of change and how do you influence a protocol at your institution.
Ellie?
Yeah, I was going to say the protocol thing, because I think I take advantage being in an established program that protocols exist. But as listeners, you might be working somewhere where they don't have this. They don't have an axillary ultrasound protocol. You're the one who kind of has to pick up the rock and say, hey guys, we should really be doing this. So I think the importance of protocols and implementing that just can't be overstated. And that's how we kind of move the needle forward, is create protocols and get everybody on the same team.
Michael?
just be that agent of change. Be that person that's willing to push that needle, because if you don't have that person in your tumor board, nothing moves forward, everything stays the same, and it gets very sluggish. If you can be that person that's willing to push the envelope a little bit, not recklessly, but to ask the questions and get everybody involved and make people make decisions for change, that's how we're going to get de-escalation, and that's how we're going to advance the field.
I'm not sure that we answered any question for our listeners today. And as Michael says, we never do. But I think these are three of the most important takeaway messages that we have had about develop protocols. Be the person, take the lead, take that chance and say, hey, let's develop a protocol based on this. Now, it may not be exactly what you want, but it is consensus, and that's really critical. It's so important for us, but more so, it's really important for our patients. So thank you for this discussion. Maybe one of these podcasts will actually answer a question as opposed to just raising more. But to all of our listeners throughout the entire breast community, once again, we're thrilled that you've joined us on this journey, and we'll see you the next time on the next Breast Thing podcast.
We look forward to connecting with you on the next episode of The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the breast community.
Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
Finally, the content within the Next Breast Thing podcast represents the views, thoughts, and opinions of the co-host and may not necessarily reflect the views, thoughts, and opinions of the American Society of Breast Surgeons.
Until next time, this is Carla,
Ellie,
Michael,
Susie,
and Susan. And always remember, if you're part of the breast community and can't seem to find the answers, this is the next breast thing.